So again, thanks for everybody for coming out today. This is the third installment of our Orthopedic Journal Club, and it's really, really cool to get some buy-in and participation. So today we wanted to cover something that's practical and universal, so just knee osteoarthritis. And obviously part of the goal here is to build comfort with orthopedic clinical language and specialty research. This isn't just an ortho topic. This is something that every primary care and frontline physician is going to encounter at some stage of life. So our goal today is to walk through what the options actually are when patients develop osteoarthritis, from conservative care and injections all the way through to surgery, and talk through kind of the pros, cons, and realistic expectations of each. As Tariq and I's mentor, Dr. Atkins, says, osteoarthritis is the gray hair of orthopedics. It's something we'll all encounter and something that every one of our future patients will face in some form. So the earlier we understand it, the better we can guide them through it. So a little anatomy to start us off. The knee is a classic synovial hinge joint connecting the distal femur, proximal tibia, and patella, with the fibular head adding a little bit of lateral stability. That lateral stability depends on the cruciate and collateral ligaments. And then, of course, the menisci act as the joint's shock absorber and load distributors. And then the articular cartilage is multi-layered with some collagen fibers running parallel to the surface for some shear resistance, and then perpendicular in some of the deeper zones to handle the compressive load. And a fun fact about our articular cartilage is that it actually has a friction coefficient of more than 100 times lower than two pieces of polished ice sliding against each other when it's nice and healthy. To support that, we have chondrocytes that maintain a matrix of type 2 collagen and aggregate proteoglycans. Of course, the synovial membrane lines that capsule and secretes some synovial fluid rich in hyaluronic acid and lubricant, which together provide viscosity and reduce friction. And then in osteoarthritis, both the quantity and quality of that hyaluronic acid decline, and inflammation starts to alter that fluid's protective function, which kind of sets the stage for cartilage degradation, which links directly to the visco supplementation. Some of the other treatment options we'll cover a little bit later. So that's what a healthy knee looks like. That's hopefully what most of us are walking around on, but let's talk about how it starts to break down, especially from a histological perspective. So the earliest degenerative process in OA begins at that articular cartilage surface. We see fibrillation, proteoglycan loss, and chondrocyte clustering, which in totality is actually the cell attempting to repair itself, but it ends up worsening disorganization over time. The proteoglycan loss represents the depletion of glycosaminoglycans, which normally hold water and give cartilage its cushion. So it's the start of mechanical failure. And we'll come back to some of those later because the stress response that's really important here is eventually subchondral remodeling and bone spur formation that kind of comes on when OA advances. So the first image here on the panel is the first few weeks of breakdown. And just to kind of note and orient you really quickly, this is a study that uses a mouse model to actually show cartilage breakdown histologically. So when you see like intra-articular injection at the bottom there, what it actually represents is the injection of compounds aimed at accelerating the natural arthritic process. So even in this first slide, we can see how the cartilage surface begins to fray. There's proteoglycan depletion staining lighter than normal. And the researchers even note at this very acute phase that there is already some damage to cartilage, ligaments, and tendons. As the process starts to kind of progress, we'll see chronic instability and ligament disruption. We'll start to see even some deep fissures and subchondral bone thickening, which are those darker bands that you can see underneath the actual articular surface. So that's actually sclerosis. And in this context, what sclerosis kind of refers to is the subchondral bone thickening and hardening in response to that increased load. So it's kind of like the bone's way of overcompensating for that failing cartilage. And as it starts to absorb more stress, it tries to stabilize the joint, and that adaptive response ultimately drives osteophyte, aka bone spur formation, which is again a part of the maladaptive repair process. Once you get to the chronic phase on the far right, instability and ligament failure have progressed to meniscal degeneration. So at this point, the meniscus is totally extruded out of the knee, and it's no longer cushioning the joint at all. So you are truly bone on bone. And every step transmits force directly through that exposed bone, which drives pain, deformity, and just continues the OA cycle in general. Once inflammation sets in, the synovium becomes the real driver of disease. It starts to release enzymes and inflammatory signals that break down hyaluronic acid, and contributes to oxidative stress that will continue to chip away at that cartilage matrix. In a healthy knee, the joint fluid has a consistency of kind of like honey, roughly, is how it's usually described to people, which cushions every step. In osteoarthritis, it starts to thin out and become really watery, so the joint starts to kind of grind instead of glide. It also has lubricant in it, which is another really key lubricant in the knee joint, and that also starts to drop, which increases friction and overall surface wear. Once you get to some of these advanced stages, as you can see, the cartilage in that medial compartment in this photo on the right here is pretty well completely gone. It's pretty close to bone-on-bone contact. And if you start to think about that, what that actually kind of means anatomically, it means that meniscus is all the way out of that knee. It's extruded and degenerated. So it's no longer sitting between the femur and the tibia to actually distribute that load. So again, every step transmits force directly through that subchondral bone, which, like we just talked about, contributes to this process in general. But it's important to highlight, like we'll talk about a lot today, even at this point, surgery is not your only option. We still have treatments that can calm inflammation, restore some lubrication of the joint, and hopefully help patients stay mobile, even when the radiographs look pretty severe. So the pathological process, it's important to note that osteoarthritis isn't just cartilage wearing out. It's a full-blown biochemical and biomechanical feedback loop. It starts with some cytokines like IL-1 and TNF-alpha telling chondrocytes to crank out matrix-degrading enzymes. And those enzymes end up kind of chewing through the collagen and aggrecan while oxidative stress breaks down the hyaluronic acid and again just thins out that joint fluid. On the mechanical side, it's really important to skip over this step because varus alignment, for example, drives the leg's weight-bearing axis inward. So most of the force lands on that medial compartment. And again, if your meniscus is already extruded, which it will be in bone-on-bone, that hoop stress is gone and load concentrates on a tiny little patch of cartilage, which is just going to further the breakdown. And then, of course, if you add in weak quads and hip adductors, you lose the dynamic stability that could dampen those forces. And the result is, again, a vicious cycle where inflammation and malalignment continuously amplify one another. So that's why the treatment ladder targets both sides of this loop, both mechanical load and inflammation, to hopefully slow progression and preserve function before surgery becomes a complete necessity. So the treatment tree, again, every major guideline agrees that the treatment for OA starts long before we get to a needle or a scalpel. It's, again, an important piece to not skip over core care, like education, exercise, and weight loss. It's been shown that even a 5 to 10% weight reduction can cut joint load dramatically. And exercise, especially supervised strength and balance training, outperforms injections at 1 year in some trials. Things like bracing are also really important. Certain kinds of braces, if affixed in a personalized way, can actually correct some biomechanical issues like that aforementioned valgus deformity and lead to increased exercise tolerance and pain reduction. However, if pain persists, topical NSAIDs are definitely your safest first add-on. Oral NSAIDs, depending on if the patient has any GI or cardiovascular issues. And acetaminophen has pretty modest effect. There's actually even been studies that duloxetine works pretty well, which is actually a serotonin norepinephrine reuptake inhibitor and can be helpful in some patients who have chronic or centrally amplified pain. And for some people, especially if it's really bad, they may have concurrent depression, and duloxetine is fantastic for that. So again, the theme here that we're starting to kind of hone in on here is conservative treatment first. Try to optimize and reassess your patient before escalating. And then once those foundational steps are maximized and symptoms are, remain really limiting, that's where we start to consider some procedural options. So once optimization and conservative care fails, we have to move into the procedural tier, unfortunately. The first one that I'll go into a little bit more in a minute is corticosteroid injections. These are the most common procedure we use for knee osteoarthritis, and they provide strong short-term pain relief, but we need to be really careful with repeat injections because over time, they can accelerate cartilage degeneration, and they can end up thinning out the joint space even more. So they're really good for acute flares or bridge therapy, aka getting someone out of pain and getting them to PT, but they're not something we want to do every few months indefinitely. Hyaluronic acid, or visco, as we're going to refer to it a little bit later, aims to restore the joint's natural lubrication by supplementing the degraded synovial fluid. Literature is a little bit mixed, but it's really good for some patients who can't take NSAIDs or steroids or find minimal improvement with other options. Beyond just pure lubrication, though, it does actually stimulate our own production of hyaluronic acid and lubricant, the two things we've talked about already, that we've seen break down in this process. So in a sense, it tries to nudge the joint back towards a more natural environment is sort of a way to think about it. And really important, unlike corticosteroids, visco injections have no systemic effects. So that means I could safely give this injection to an 105-year-old diabetic without worrying about their blood sugar or any systemic flare. And I'll let Tariq get a little bit into that a little bit later. Quick comprehension check though for anybody. Does anyone know what that orange stuff in this image is, this horrible image? Sure, somebody does, but don't worry. It is betadine. So it's a topical antiseptic. And you got to think we're injecting into the synovial fluid. This is an intra-articular injection, and it's going to just prevent potential infection. PRP, another potential option for people, platelet-rich plasma, which is still kind of considered investigative in most settings. Some meta-analysis suggest it might provide slightly longer pain relief than hyaluronic acid or corticosteroids, but the protocols from clinical to clinic and study to study vary so much, it's kind of impossible to standardize or compare results. And coverage is really limited. So for most patients, they're paying thousands of dollars out of pocket. And it's really important to note here as well, too, it is not FDA approved for knee osteoarthritis, while visco injections are. So that kind of says a lot about where the current evidence and regulatory confidence stands. And all in all, it tends to just be exceptionally expensive for benefit that remains pretty difficult to quantify. One that you really rarely will see is genicular nerve ablation. You'll see it maybe in pain management or interventional radiology clinics. Definitely not typical orthopedic practice. This is, really rare, limited usage when patient might have like severe osteoarthritis or can't undergo surgery and has failed some other treatments. Evidence is really limited, but again, really just used in like end-stage non-surgical candidates. Arthroscopy, one of the mainstays of orthopedics in general, is not recommended for OA. We use it if there's a true mechanical issue like a meniscal tear or like a loose body in the knee somewhere that explains the pain, but not for general arthritic changes. And then lastly, when all else fails and pain or functional loss truly limits quality of life, we discuss surgical referral, which could look like a unicompartmental knee replacement if the disease is localized and the patient's alignment doesn't look like it's going to predispose them to continued wear, or of course, a total knee arthroplasty for a global knee problem. But again, the key, something that both Tariq and I's mentor, Dr. Atkin, always emphasizes is arthroplasty isn't the finish line. It's one option amongst many. The real art of this entire process, this entire presentation in general, is matching the treatment to the patient's goals, activity demands, comorbidities, and expectations. So we preserve their function as long as possible before we feel forced to cross over that surgical threshold. And then before I hand it off to Tariq for a deeper dive into some of the other procedural evidence, I do want to take a second to focus on corticosteroid injections because this is by far the most common and probably the most misunderstood intervention in this entire ladder. And again, regardless of orthopedics or primary care, we will all encounter corticosteroid injections. All right, so really quick, this is our quickest way to calm an angry knee. We typically use something like methylprednisone at about 40 milligrams. Pain relief comes in really fast within like a week and then fades by usually about a month, sometimes a little bit longer. And it is really, really good for certain things. And this is just a little graph here showing that you can see the pain starts coming back after 8 weeks, generally speaking. Really ideal for things like acute flares and large effusions that you can see on this ultrasound image here. And we can even use it for other things like pes-anserine bursitis, prepatellar bursitis, IT band friction, when inflammation is really clearly localized to those structures. Systemically, the risk is low but real. Some patients can experience a transient steroid flare, which looks like brief pain and swelling for like 24 to 48 hours after the injection. Short-term systemic absorption can cause things like transient hyperglycemia or even a mild bump in cortisol. So that's why we avoid these typically in poorly controlled diabetics or around major surgeries, maybe even vaccination windows. And it's really key to note that at least two giant studies have been repeated over time to show kind of two key things. One is that if given every 3 months for 2 years, we're definitely going to lead to cartilage thinning without better pain or without pain reduction better than saline. So it really will thin out that cartilage. And even a 2020 study looked at corticosteroid injections compared to physical therapy and found that PT provided greater functional improvement at 1 year. So they're a great short-term tool, but not maintenance therapy. A really good way to reset inflammation so patients can move, strengthen, and re-engage with things like rehab. But as a rule of thumb, we want to keep it to like 3 or 4 injections per year per joint. If we're doing more than that, then we probably need to rethink our plan a little bit here. All right, and probably the most hardcore farm slide we'll do today. Let's just make Dr. Murakami proud here a minute and spend a minute on pharmacology. So if you haven't had his lecture, I don't know where the OMS-Is are at. This is a perfect real-world example of why prostaglandins and steroids do matter. So mechanistically, we can think of corticosteroids kind of working on two levels. First, they boost a protein called annexin A1, which blocks an enzyme, phospholipase A2, which normally releases arachidonic acid, which is the starting material for the COX and the LOX pathways. And if we cut off that supply, both those pathways drop. We get less prostaglandins, we get less leukotrienes, which means less pain, swelling, and heat. It also works on a more genomic level here, where once the corticosteroid receptor complex forms in the cytoplasm, it translocates into the nucleus and binds to a couple different sequences of DNA, one of which being the glucocorticoid response element. There's both a positive and a negative. When it connects to the positive response element, it's going to turn on transcription of key anti-inflammatory genes, things like annexin A1, interleukin 10, and these proteins go on to block phospholipase A2, like we were just talking about, interleukin 10, which dampens some cytokine responses. And again, overall is just a series of anti-inflammatory genes that are very beneficial. The same complex can also bind to a negative glucocorticoid response element on another part of the genome, which turns off the transcription factor for some pro-inflammatory mediators such as interleukin 1 beta, tumor necrosis factor alpha, and cyclooxygenase 2. So together, these dual genomic effects and activation of anti-inflammatory genes and repression of pro-inflammatory genes create a really powerful local shutdown of the inflammatory cascade and reinforce the enzymatic blockade that can lead to so many problems here. And again, here's just one other one that it blocks as well too. NF-kappa B is a really, really important one. Again, I actually accidentally drew it already in the nucleus, but these are pathways you don't need to have memorized. It's just really good to know that this is a very multifactorial pathway to block inflammation. Because overall, clinically, what this all leads to, really the important thing here, it leads to less vascular leak, fewer white blood cells migrating into the joint, and a really rapid drop in synovitis, right? The inflammation of that synovium, which is leading to a lot of the disease progression here. And it's a really, really good mechanism. It's really well understood, obviously, but once gene expression resets, once new cells are formed, all of this benefit fades away, which is the direct explanation for why something like a corticosteroid injection only lasts a couple of weeks to maybe a month or two at the absolute most. Lastly, let's just go over kind of the best clinical approaches. So pick patients who'll feel it, right? If they have an acute flare or like a big effusion, and if they have a really big effusion, aspirate it first if there's some real volume there. Use a sterile prep and utilize ultrasound guidance if it's a tricky knee, especially ones where there's really thin joint space, like some of the images we've shown so far. Using ultrasound can make getting your needle in there a lot easier. Safety-wise, counsel patients on transient hyperglycemia, and again, avoid it close to surgery or vaccines. And if you find that you're using it all the time, like under that 4 to 6 week window, even sooner than that, or you're using it all the time, more than 3 or 4 times per year on the same joint, it's time to consider other things like PT or weight loss, consider visco for lubrication without systemic effects, and again, potentially think about surgery. So with corticosteroids, hopefully appropriately framed in all your minds as a really good short-term anti-inflammatory option. The next step, or really what I would consider to be the best step for most, is restoring that natural joint environment. So Tariq is going to walk us through Visco, why it's FDA approved, and how it can kind of nudge this joint environment back to normal, and where it outperforms other really costly options like PRP. And how we decided we're going to do this is I'm going to actually just hand this back to him.
Thank you, Jack. Yeah, just give us a moment here while we switch gears so I don't have to have Jack tap through every next slide for me.
Yeah, I think we tried, and that was not going to be a good solution. Beautiful.
Alrighty, switch gears here. Alrighty, is everyone able to see my screen okay? Perfect, thank you. Great to see new people and familiar faces. Thank you, Jack, for that wonderful presentation. So now we're just going to talk a little bit about visco, PRP, surgery, and then some cost considerations. So viscosupplementation, what is it? It's an intra-articular injection that stands for hyaluronic acid, right? And hyaluronic acid is a long polysaccharide chain, and hyaluronic acid is already naturally occurring in our joints. I'm just going to abbreviate it HA so I don't have to keep saying hyaluronic acid every time. So HA is a naturally occurring component both in the synovium and the cartilage. So in a healthy joint, HA is going to provide a viscoelastic property, and that's going to serve for some shock absorption, for lubrication, for cartilage protection. It's very essential to a healthy joint. Compare that with knee osteoarthritis. What do we have? We get a qualitative and a quantitative deficiency of hyaluronic acid. So that bioviscoelasticity property of HA is decreased, and therefore that leads to less protection to the cartilage, resulting in cartilage damage. So what is the goal of visco? Visco, the goal of it is twofold. One, as the name suggests, it provides a supplement of exogenous HA, and the second goal is to induce an autocrine signaling for your body to actually increase its own natural bioproduction of HA. So HA itself is taken up by specific joint receptors in the knee, and these lead to very good beneficial biologic effects. This includes moderate anti-inflammatory actions. It reduces that cytokine-induced storm, which mostly on its own would degrade cartilage. It also presents with an antioxidant action. There's also studies that have recently shown there's actually an anabolic effect on cartilage because it stimulates that chondrocyte metabolism. There's also some people report that there's a direct analgesic component. That's still a little debated, but there is evidence that it has direct analgesia by masking those joint nociceptors. And the visco-inductive properties, like the stimulating synoviocyte-mediated production that Jack talked about a little bit earlier for endogenous HA, that actually is what accounts for the prolonged efficacy, despite that HA itself as a substance lasts a very short time in the actual joint space, but its prolonged effects last for very long, and that's what makes it a very useful modality for treatment. So next, we're going to talk about viscosupplementation and who gets it. Bottom line, patients with chronic, moderate symptomatic OA, not for people with flares, not for people with joint swelling. So we're going to go with this table, a couple conditions, requirements, and talk about details for that. So in general context, OA must be symptomatic, and medical treatment, like non-pharmacological treatments, analgesics, NSAIDs, etc., they must have failed, or the patient has to achieve an intolerance to those medications. The ideal phenotype is someone with moderate femoral tibial osteoarthritis that does not show any swelling. And that's based on the Kellgren and Lawrence grades 2 and 3 osteoarthritis. I'll talk a little bit about that on the side a little after this slide. But just quickly, Kellgren and Lawrence is a widely used method for classifying the severity of osteoarthritis, and it's based on x-rays. So it's primarily used for the knee. It's a 5-point scale, but it's graded 0 to 4. 4 is going to be very severe bone-on-bone arthritis, and 0 is going to be very mild, minimal changes in the joint space arthritis. And it looks for stuff like joint space narrowing, osteophytes, which is a fancy way to say bone spurs, or sclerosis. Not indicated or contraindicated, it's not indicated for people with flares of joint swelling or acute inflammation known as synovitis. If an effusion is present, that doesn't mean it automatically eliminates the candidate for hyaluronic acid supplementation, but that effusion should be treated first, and that's usually with rest, ice, NSAIDs, and sometimes even corticosteroids. The key is, though, when you treat that, you cannot jump right away into an HA injection. It's optimal to wait 1 to 4 weeks post-treating that effusion before even considering starting HA therapy. And this is, like I mentioned, kind of really for mild to moderate osteoarthritis because, like we mentioned before, when you have severe osteoarthritis, you have bone-on-bone. there's not even much space for synovial fluid to kind of increase that autocrine production itself. But recent studies have shown that there is a possibility of efficacy even in highly advanced knee OA, which is grade 4, where it can provide some interim relief in the context of a patient waiting for arthroplasty. So it's not necessarily like a treatment for someone with severe arthritis, more so of like, okay, if this patient can't get surgery then and there, but they're in excruciating pain, it could be an acceptable modality to reduce that pain until we are at a more appropriate time for surgery. Some specific populations to consider that might be even more beneficial for is people over 75 years old. It's a good alternative for older patients and those who also have NSAID-induced adverse events. But one, Jack alluded to, I'm going to touch a little bit more about it, very, very, very advantageous treatment modality for people with uncontrolled diabetes. Because corticosteroid injections, it spikes your cortisol, spikes your blood sugar levels, and people can have like hyperglycemic attacks with corticosteroid injections. But this is just a natural supplementation of something already occurring in your body. There's not going to be any spikes in blood sugar associated with it like there's corticosteroids, so it makes it a very good option for diabetic patients. Also, it can be used as an adjunct therapy. So some people get conservative surgeries not really related to arthritis, maybe like an arthroscopic treatment of a meniscal lesion, and they can present with pain post-op. So this can be used as like a secondary measure after surgery if pain persists even after the surgical treatment for other conditions. Really quickly, this is just a side note. I talked about it. This is really important. You're going to see it in many settings, primary care and orthopedics. This is the Kellgren-Lawrence scale. It's one of the most commonly used scales. As you can see here, it's 5 points, right? We have from normal, doubtful, mild, moderate, severe, but it's graded 1 through 4. So grade 1 here, you can see very mild reduction in the joint space here. This is our femur here, this is our tibia, so this is the joint space between the two. When we get to grade 2, you can see in the medial compartment, it begins to slightly narrow in that joint space, but still kind of mild. Grade 3 is when we see a more significant reduction in that joint space here, as you can tell. And then grade 4, that entire medial compartment is gone. There's pretty much bone on bone. There's no more joint space left. So that's just a quick aside about what the Kellgren-Lawrence scale assesses. And so viscosupplementation, we're going to talk about a little bit treatment courses, safety, and adverse events. So typically it's 1 to 5 injections in the interval of 1 to 5 weeks. Some orthopedic surgeons do it 1 to 4 weeks. But in knee osteoarthritis, a series of 3 injections at 1 week intervals is the most common. Some people use single injections, but all the studies there point to having at least 3 is the most optimal. Multiple injections are deemed superior, and yearly renewal is only indicated if symptoms reoccur after that initial course of treatment. So product derivatives, hyaluronic acid is pretty standard from brand to brand, but the biggest difference is, I don't want to get too much into like the molecular chemistry of it, but it's chain length, molecular weight, and structure. And by structure, I mean whether it's a linear hyaluronic acid or a cross-linked hyaluronic acid. So some of the studies Jack and I were reading about, it actually showed that the cross-linked hyaluronic acid forms, which have a higher molecular weight, did present with slower degradation and longer joint residence of the actual injection, allowing for single injection schedules at times. So people found that if the molecular weight of the HA was 3 or greater, it stayed around the joint for longer and it had a longer efficacy effect. So that's still like something being studied. Does that really matter? But the data is showing that higher molecular weight with cross-linked HA is optimal. And one brand that does that really well is Suparts. That's kind of like the forefront of like people who, the orthopedic surgeons, they prefer that brand more than others because it's very high molecular weight and has really good outcomes. But overall, just like I mentioned, analysis differentiating those products has shown no real significant differences in effectiveness between different viscosupplementation formulas. General tolerance, the tolerance of these shots are excellent. Local tolerance is very satisfactory. The local reactions that occur, very mild, moderate adverse events. They're generally reported after the injection itself. The most common being injection site pain from the actual needle. Post-injection pain can be limited, however, with very good injection technique under ultrasound guidance. And as with any injection, it's going to be infection is one of the more serious and largest risks. But like Jack mentioned, if you put the betadine, if you put proper solution to sanitize and aseptic techniques, that significantly reduces that risk. Contraindications, we touched base on this a little bit earlier. Hyaluronic injections is contraindicated in patients with acute inflammation or severe effusion. And it's important, I want to say one more time, that if anyone has an acute inflammation or severe infusion, the data shows you must postpone HA treatment for at least 1 to 4 weeks until the synovitis is treated. And just to take a break from the science and a little quick fun fact. Rooster combs. Now you might be saying, why am I putting rooster combs up here? So actually, the injections are animal derived. And where do they get the actual hyaluronic from? It's from the combs of roosters. So something you have to keep in mind to ask your patients is, hey, and it's not very common, but do you have an allergy to chicken, or do you have any avian adjacent allergies? Because that could trigger anaphylaxis if they do have a reaction to that, because this is the main source of where hyaluronic acid is derived from. Go figure. Alrighty, and viscosupplementation, what did this data show? So, okay, we know osteoarthritis, the cartilage wears away, bone spurs may develop, and the joint fluid breaks down. We've given visco. Now what? What does the data show? So some older studies from the late 2010s to the early 2020s showed a very high overall response rate of 60 to 70%, and recent data shows even a higher number than that. Meta-analysis in the past has shown only a small reduction in pain, but I want you to bear with me because while that may seem 20% is low, we have to keep in mind this is not the main goal of viscosupplementation. The key difference for viscosupplementation is that we're looking for long-term outcomes. Corticosteroids, elite for short-term pain relief in order to get a patient to be able to complete their physical therapy and their rehab. Viscosupplementation, some people report up to 20% of pain reduction, but the key here is the delayed onset with a longer sustained outcome of pain-free osteoarthritis. And the efficacy period from the data shows that it becomes typically significant pain reduction at 4 weeks, peaks around 8 weeks, and can persist from up to 6 to 12 months. So that's the key difference here. Visco is focusing on long-term outcomes, whereas corticosteroid is focusing on short-term pain reduction in order for a patient to be able to complete physical therapy. So also visco allows the patient to reduce their reliance on various analgesics and NSAIDs, improving the overall risk-benefit ratio for the patient as a whole, especially for the elderly population. So in a nutshell, one of the strongest arguments for using HA is its favorable therapeutic trajectory. Unlike traditional pain medications, HA acts only locally and systemically through an autocrine-induced mechanism, through anti-inflammatory properties and even analgesic effects. Okay, so we talked about HA. HA is FDA approved for osteoarthritis. It's covered by most insurances. Let's talk about something that's a little bit new to the field. PRP injections, which stands for platelet-rich plasmas. So PRP is derived from a patient's own blood. So you go in, they take a blood draw, they send it to the lab, they centrifuge super fast, and they isolate those platelets, which in theory has a bunch of growth factors. And those growth factors are thought to have anti-inflammatory properties and actually a matrix for restorative mechanisms of osteoarthritis. So what are the goals here? The goal is to address the underlying pathology, like cartilage degradation, subchondral bone remodeling, even potentially cartilage repair. So this is the key difference with PRP. Hyaluronic acid is focusing on a mechanical approach. I think of it as a car engine. Hyaluronic acid, I'm replacing my car's oil. With PRP, I'm essentially trying to repop the whole engine, maybe put a new engine that can perform better. So one is kind of regenerative, the other one is more of a mechanical approach. It started as a marketing kind of treatment for people. It was like, you know, we have a good science, but it wasn't really science-backed. But now science is actually showing it might be clinically effective. In fact, there are some randomized controlled trials and meta-analyses from within the past 5 years that showed short-term pain and function benefit, and some of them even superior to hyaluronic acid, but the durability of those were uncertain. The evidence quality is mixed because it's not standardized. Every patient's component, since it's your own body producing the medicine, every patient's different. There's no standardized protocol for it because it's not FDA approved, and cost and coverage is a main barrier because it's very expensive to get these injections, and insurance will not cover for it. So most people who get it are paying out of pocket all the time. So it's emerging, it's investigational, it is controversial in the sense that the effectiveness isn't always evident in the science because of the specific heterogeneity and lack of standardized protocols like I mentioned. But one interesting thing that I just want to allude to is a lot of the papers started to look at, okay, some PRPs are working for others and some is not. So what might be going on? They took a closer look at how some labs isolate PRP. Now there's two categories that they looked at. They looked at something called L-PRP, which is platelet-rich plasma and leukocyte-rich plasma. And then they looked at pure PRP, which is just pure platelet plasma. They found that the concentration of leukocytes in L-PRP may actually have an adverse effect. It can initiate catabolic enzymes rather than anabolic enzymes. So they found that treatments of PRP that have more leukocyte counts actually induce IL-1 beta and TNF alpha, those inflammatory cascades, that could adversely affect the chondrocytes. Versus when they're looking at the other ones that have just purely platelet-rich plasma, they found more promotion of the growth factors. So that's another field that people are trying to look into that can signify, hey, maybe it's not PRP as a whole that might have been a marketing sham. Maybe it's the fact that we weren't focusing on having pure platelet-rich plasma and including leukocytes in there. So the data as it shows today, though, just says that you should avoid it, just in the sense of if someone has a coagulopathy or active infection, just don't even consider that for them. That will lead to a whole other cascade of inflammatory markers that will worsen another condition. But the rate of adverse side effects also has been shown to be a little bit higher in PRP at about 13% compared to hyaluronic acid injections at about 9% in one of the meta-analyses. Adverse events were also like local soreness, injection, pain site, but also that catabolic effect I was talking about earlier. And as for the American Academy of Orthopedic Surgeons, their stance on this is a very limited recommendation for PRP. They acknowledge that it may reduce some pain and improve function, but they downgrade their recommendation due to concerns about inconsistent evidence and reports of systemic adverse events. Some of those adverse events, just for reference, I won't talk about it too much. There were some hypertensive episodes, proteinuria, treatment related, and even some common toxicity criteria with a grade greater than 3. So there was a lot of systemic issues that were reported in some of these studies. Alrighty, so now we've talked about PT, we talked about NSAIDs, we talked about corticosteroids and visco. None of that worked. When is it appropriate to consider surgery? So we want to consider surgery when there's persistent pain, disability despite optimized non-operative care with exercise, PT, etc., radiographic findings of OA correlating with symptoms that impact quality of life and daily activities, particularly when it's like end-stage tricompartmental osteoarthritis, which means that the lateral component, medial component, and the patellofemoral component are all arthritic end stage. But really what we want to do, like Dr. Atkin, our mentor, mentioned to me and Jack, is when your patient comes into with arthritis, think of it as if they're coming into a restaurant, and your job is to give them the full menu. They can see everything that's on there, but they might not be hungry. They might not want the corticosteroid. They might not want the surgery, but they want to know what options they have. So it's our job as physicians to not only know the science, but to know each patient's individual goals and what they want. It's about quality of life and pain tolerance. It's not an emergent procedure. You have to reassure them this is not going to kill you. This is not going to be something that's going to really harm your life. It's all about what are your goals? Is this really bothering your quality of life? And is this something that's causing you immense pain? And if so, we have so many treatment modalities for you. So you have to keep that in mind. So just to talk a little bit about what a unicompartmental is, you can see here the entire knee is replaced in a total, and then just the arthritic portion is replaced in a unicompartmental. It's isolated mostly for medial or lateral compartment, but the important thing to consider for a UKA is that the ACL has to be intact, and also if the patient has any valgus or varus deformities, that it could be correctable with the UKA procedure. So that's just something to keep in mind. In terms of outcomes, a total knee replacement is reliable pain relief and function. It's kind of the gold standard for surgical procedures for end-stage tricompartmental or OA. Highly successful procedure, providing significant symptom improvement and functional gain. It has a much better long-term efficacy and function scores compared to a UKA. But why might someone consider UKA? UKAs have a faster recovery period, and it also gives the body a more natural kinematic chain because you're not removing the whole knee, you're just removing a piece of it. So that you do have some better natural preservation of your natural kinematics. But the caveat to that is there is a higher revision risk. So offers better efficacy in the short term, but in the long term, there's a high rate of revision. But conversely to that, there's also a lower occurrence of major complications. So it's kind of, you have to really make a good clinical judgment about what's best for your patient. And then tying it back to hyaluronic acid injections. So with everything I said, I just want to take a moment. We want to try to have these presentations be a little bit more collaborative going on. So I just want to give you a question, food for thought. Give you a minute to answer, and don't worry, there's no right or wrong answer, just something to think about. So if we talked about hyaluronic acid injections can delay the need for a total knee arthroplasty by roughly 2 years, considering the short-term benefits of UKA versus the higher revision risk, how should we prioritize an injection treatment that extends the function of a native joint like hyaluronic acid or PRP versus optimizing for a UKA, which preserves some native bone but increases the chance of a later revision TKA? So if you feel comfortable giving some insight, that's fine. If not, I'm just going to take like a quick 30 seconds for everyone to ponder about this. And there's no real right or wrong answer, but just we'll talk a little bit about after that where you should guide your thinking to that question.
Tariq, that was a long question. Can you repeat it one more time?
Yes, I realized that I was saying it. Sorry. So basically, let's talk about HA, right? So HA, it delays the need for surgery by roughly 2 years if it's successful. So we consider short-term benefits of UKA, right, which is unicompartmental. We know that there's better short-term benefits for a UKA, but there's a higher revision risk down the line. So keeping that in mind, as a physician, how do you prioritize injection treatment? Because injection treatment is going to naturally extend the function of a native joint of hyaluronic acid and PRP. It's also going to think about how you're going to opt for a UKA, which preserves the native bone, but then also increases the chance of a later revision TKA. In a nutshell, all these treatments that you have, how do you think about choosing one that's appropriate for your patient? And I can try to share the entire screen so you can see my speaker notes, and I'll just highlight the actual question. But I don't want to spend like too much time. I know we're running a little close to 4:30, so I'll just share the whole screen here. Give me a second. Okay, and then I'll reshare. So this is the question right here. Ignore the answer. I can't block that out. Maybe I can. Okay. Yeah, just think about it. In the interest of time, I'll just give like quick 30 seconds and I'll just kind of just talk about it unless anyone really is adamant about sharing. So just keep that in mind. There's no real right answer, but the biggest thing here is that with all things in medicine, we treat the patient and not the disease. The decision between pursuing non-surgical injection treatments to delay surgery versus optimizing for surgery, it's a complex trade-off between prioritizing the native joint function and managing surgical risks and long-term longevity. So the priority should generally be favoring the extended natural function of the native joint and delaying surgery as much as possible. Because surgery is invasive, surgery is costly, and surgery comes with more risks. The overarching principle is that we want to preserve the native joint, avoid surgery because it carries immense value. And ultimately, it comes down to the patient. What does the patient want? What's the patient's goal? And what's their desired quality of life? You have to keep an informed decision-making with the patient. Ultimately, that's what should drive the decision-making. Okay, and I'm not going to play this video, but I will open another tab if you want to see it. It's just a quick 2-minute thing on what one approach is to a knee replacement if you're interested about how they approach it. It's not for business owners. It's a total knee replacement video. I will share this with everyone afterwards, but sorry. Thank you for that. Anyways, next on, let's see here. So now we're going to talk really quickly just to wrap this all up. We're going to talk about healthcare costs and Medicare coverage. So we arrive at the economic landscape, which heavily influences treatment that patients actually receive. And now think about how inflation has increased over the years. In 2012, where prices were still relatively cheap, OA market on treatment exceeded $11 billion in 2012 alone. And that number has been climbing up at a steady 6 to 8% every single year. We start with the surgery costs, where TKA itself is inherently expensive. The average inpatient in the last 5 to 7 years, the average total of cost has been about $20,000 to $25,000 for a TKA in an inpatient setting. It is a very expensive procedure, but it's highly cost effective because over a patient's lifetime, it's going to really improve the quality adjusted life years for a patient, and they're going to have minimal risk of revision or long-term complications with that. And now let's look at viscosupplementation. So whatever ongoing debate still exists in the clinical world, IAHAs is widely utilized, widely covered, and Medicare even covers it, and most major insurance companies approve their insurance funds for hyaluronic acid supplementation. And in 2018 alone, when they saw the real market boom and usage of this supplement, they spent $325 million in coverage care for viscosupplementation. And that number has increased today. So it's approved, and it's a good thing to consider if your patient is on Medicare, to know that this is available and something that can really help them without hurting the bank too much for patients who are from an underprivileged background. So the economic argument for hyaluronic acid is twofold. You have to demonstrate that the products work and the products are cost effective. I'm not going to get too much into the numbers. If you're really curious about the mechanics, the finances about this, send me an email. I can send you all the research I did on the finances. But just for the final point I want to make about finances is it's the comparison of the core treatments like PT, education, that often have a low cost and highly cost effective. And then we get up to like median cost of injections and higher cost of TKAs. we have to, as physicians, not only know the science, but we have to know the social and economic determinants of health that our patients are facing. Because not every patient is going to have access to the same insurance policies. Not every patient is going to have the ability to pay out of pocket for something like a PRP. So it's up to us to kind of know what's accepted on Medicare, what's accepted in most major insurance plans, and kind of guide our patients' care in a way that not only helps them clinically, but helps them socially and economically as well. So that's just food for a thought. And I'll let you guys read this for a second, just at your own pace. We don't need an answer for this, but just something I want you to think about that kind of ties in everything, like clinical aspects, economic aspects, etc. So just give you guys a second to read that green text at the bottom. Alrighty. And then again, if you're interested more in the finances, I have a whole like 2-page thing on all this financial analysis. Just send me an email. I'll be happy to share it with you. So that brings us to our last point right here, which is kind of what we are trying to accomplish with this group, is getting a bunch of research experience. So in the papers that Jack and I read, we kind of proposed 3 topics, and we're going to have a QR code after this slide for anyone who's interested in signing up. And they're listed in order of what we think is most difficult to kind of still impactful, but for lack of better words, a lower hanging fruit. So what we realized in our research diving in this literature is that there really isn't a standardized one protocol for hyaluronic acid supplementation. Like, for example, the American College of Radiology recommends against it. Sports medicine says let's use it, but with caution. And then orthopedics, they say, no, you should use this in patients with severe OA or elderly populations. So there's no real one specific guideline looking into hyaluronic acid injection. So our first proposal was, let's look at that. Let's do a meta-analysis, and we stratify it by both the molecular properties I talked about earlier and the high-risk subgroups that might be causing those adverse studies to come out. Just to create one holistic systematic review looking at a meta-analysis of IHA efficacy and safety in new osteoarthritis. I myself have never done a meta-analysis, so if you are interested in this, I think this is going to be something that can really be significant, but don't be shied away if you've never done a meta-analysis. I've never done it, but we have wonderful mentors in Dr. Taylor and Dr. Tieford. We have a bunch of faculty who's very research advanced, and I'm sure all of us together collectively, if we're really passionate about this, I'm sure we can learn it. I'm sure we can achieve a meta-analysis paper. Second one is kind of middle route. It's a scoping review, just talking about the use and efficacy of IHA in non-knee joints and non-hip joints, because those are kind of the 2 that people use it most. Maybe looking at shoulder joints or joints in the hand, etc. And then a lower hanging fruit, but still very important to do, is a systematic review with the cost effectiveness and analysis of combination IHA therapies. There's actually papers out there that are trying to combine PRP and IAHAs into one injection. So maybe just looking at a cost-effective analysis of all the different modalities is kind of a more palpable, but still effective research topic. I'm sure we'll get plenty of feedback from Dr. Taylor and Tieford about which one of these they think is a good step forward. But with that being said, I thank you all so much for being here. I'll turn it over to Jack to talk about the QR code, and then we'll have any questions. Please feel free to ask.